Entrapment neuropathies are a group of disorders of the peripheral nerves that are characterized by pain and/or loss of function of the nerves as a result of chronic compression. Carpal tunnel syndrome is an entrapment neuropathy caused by compression of the median nerve as it travels through the wrist's carpal tunnel. It is the most common nerve entrapment neuropathy. Etiology: carpal tunnel syndrome results from increased carpal tunnel pressure and subsequent compression of the median nerve. The most common causes of carpal tunnel syndrome include genetic predisposition, history of repetitive wrist movements such as typing or machine work, as well as obesity, autoimmune disorders such as rheumatoid arthritis, and pregnancy. Typical occupations of patients with carpal tunnel syndrome include those who use computers for extended periods of time, those who use equipment that has vibration such as construction workers, and any other occupation requiring frequent repetitive movement. Pathophysiology: the compressive element of the pathophysiology includes a detrimental cycle of increased pressure, obstruction of overall venous outflow, increasing local edema, and compromise to the median nerve's intraneural microcirculation. The myelin sheath and axon develop lesions, and the surrounding connective tissues become inflamed and lose normal physiologic protective and supportive function. Repetitive traction and wrist motion exacerbates the negative environment, further injuring the nerve. Standard symptoms of carpal tunnel syndrome include dull aching discomfort in the hand, forearm, or upper arm, paresthesias in the hand, weakness or clumsiness of the hand, dry skin, swelling or color changes in the hand, occurrence of any of the above in the median distribution, provocation of symptoms by sleep, provocation of symptoms by sustained hand or arm positions, provocation of symptoms by repetitive actions of the hand or wrist, mitigation of symptoms by changing hand posture or shaking the wrist. Patients woken by paresthesias or pain in the distribution of median nerve territory, which includes the thumb and the first 2.5 fingers, have carpal tunnel syndrome until proved otherwise. Some patients will also complain of sensory disturbance in the whole hand or pain radiating up the arm to the shoulder. Patients whose paresthesias are limited to the ulnar side of the hand are unlikely to have carpal tunnel syndrome. Evaluation: the clinical physical exam may include testing for sensory and motor deficits and evidence of thenar wasting. There are several special tests with varying degrees of sensitivities and specificities. The best of these include the carpal compression test. This is done by applying firm pressure directly over the carpal tunnel for 30 seconds. The test is positive when paresthesias, pain, or other symptoms are reproduced. The square sign test is an evaluation to determine the risk of developing carpal tunnel syndrome. The test is positive if the ratio of the thickness of the wrist divided by the width of the wrist is greater than 0.7. Another test is palpatory diagnosis. In this test, the healthcare provider examines soft tissue over the median nerve for mechanical restriction. The phalanx test or reverse prayer is performed by having the patient fully flex their wrists by placing dorsal surfaces of both hands for 1 minute. A positive test is when symptoms such as numbness, tingling, pain are reproduced. The reverse phalanx or prayer test is done by having the patient extend both of their wrists by placing palmar surfaces of both hands together for 1 minute as if praying. Again, a positive test is with the reproduction of symptoms. In cases of diagnostic doubt and before surgery, nerve conduction studies should be carried out. They should include sufficient measurements to localize median nerve dysfunction to the carpal tunnel, evaluate its severity, and exclude more widespread neuropathy. An alternative or ideally complementary approach is provided by high-resolution ultrasonography of the median nerve. This image demonstrates high-resolution ultrasonography of right median nerve of a patient. Maximum cross-sectional area of the nerve just proximal to the tunnel is 19 mm square, which is more than its upper normal limit 10 mm square. MRI can make similar measurements of median nerve dimensions but is more expensive. This image demonstrates MRI of left wrist of a patient. The red circle indicates the left median nerve. Here, swelling of the median nerve is noted. Management. If carpal tunnel syndrome is identified early, conservative treatment is recommended. Initially, the patient should be instructed in modifying symptom-provoking wrist movement. This can be through proper hand ergonomics, such as placing the keyboard at a proper height and minimizing flexion, extension, abduction, and adduction of the hand when typing. It should be recommended to decrease repetitive activities if possible. Counseling on weight loss and increased aerobic activity also can be beneficial. A properly fitted nighttime wrist splint can be offered. An occupational therapist trained in hand therapy also may be a beneficial referral. Combined therapy may be more beneficial than any single treatment. A short course of non-steroidal anti-inflammatory medication can relieve symptoms, but some do not feel it of adequate benefit. A removable wrist brace that maintains the wrist at a neutral angle without applying direct compression over the carpal tunnel provides mechanical respite for the nerve. For those patients who tolerate them at night, they are often an effective way of achieving an undisturbed night's sleep. If conservative treatments are not successful, an oral or local glucocorticoid could be offered. The side effects of oral steroids preclude their routine use for carpal tunnel syndrome, but local steroid injection has no noticeable systemic effects and a very low incidence of local complications. The definitive treatment for persistent carpal tunnel syndrome is a surgical intervention with carpal tunnel release after nerve conduction studies showing significant axonal degeneration. Carpal tunnel release is typically performed by a neuro or orthopedic or plastic surgeon or hand surgeon. This procedure can be performed either open or endoscopically. Carpal tunnel release is considered a minor surgery in which the transverse carpal ligament is cut, opening more space in the carpal tunnel and decreasing pressure on the median nerve.